Hi, my name is Maddie Lee Jackson, and I'm here today to talk to you about the Asthma and the Respiratory Assessment Management Protocol here at Texas Children's Hospital. Today our objectives are to review asthma and the asthma risk factors, to review the ramp pathway at Texas Children's Hospital, to review CRS scoring and the appropriate interventions associated with each score, and finally to understand the different medications used in the ramp pathway. So asthma is the most common chronic disorder in children. It is an inflammation of the airways, and in those people with asthma, they have inflammation which causes recurrent episodes of coughing, wheezing, breathlessness, and chest tightness. Asthma exacerbations are episodic, but the underlying condition of inflammation is continuous. Environmental factors play a critical role in the asthma recognition and management. Asthma exacerbations are associated with widespread but variable airflow obstruction and are often reversible with or without treatment. Here you can see the pathophysiology of what happens when you have normal bronchial tubes and then you have bronchial tubes during an asthma attack. Asthma is a complex process that depends on the interaction of bronchoconstriction, of airway hyperresponsiveness, and airway inflammation, which results in mucus plugging and edema. In the United States, more than 10 million U.S. children under the age of 18 have been diagnosed with asthma, and 6.8 million children continue to have asthma in the United States. According to the National Health Survey in 2012, boys are more likely than girls to be diagnosed with asthma. Some of the predictors of asthma include a family history of eczema, asthma, and smoking, patient history of allergic rhinitis, sinusitis, nasal polyps, BPD, and eczema, and recurrent cough, bronchiolitis, and bronchitis. Here you can see the different asthma triggers. It can be induced with exercise, pollen, bugs in the home, chemical fumes, cold air, fungus spores, dust, smoke, strong odors, pollution, anger or stress, and pets. Risk factors for asthma-related deaths include comorbid conditions such as heart or lung disease, previous severe exacerbations or previous intubations or PICU admissions, more than 2 hospitalizations or more than 3 emergency room visits in 1 year. Another risk factor is using 1 or more canisters of Asthma in less than 1 month. Other risk factors include difficulty perceiving airway obstruction or the severity of worsening of asthma, low socioeconomic status or inner city residents, illicit drug use, and major psychosocial problems or psychiatric disease. Life-threatening asthma presents with a patient with marked chest tightness, wheezing, severe shortness of breath, retractions, cyanosis, inability to speak or speak in sentences due to dyspnea, a hunched over position, and altered mental status. Although most of our patients that we pick up already have an asthma diagnosis, and those few that may have just wheezing upon presentation, you might want to do a chest x-ray to rule out some of the conditions, which would be foreign body, heart failure, GERD, croup, or vocal cord dysfunction. So now we're going to talk a little bit more about the Respiratory Assessment and Management Protocol, or the RAMP protocol for our asthma patients. And so you would always begin with a brief history and the CRS score, which we're about to go over in just a few slides. We would administer oxygen to maintain our SAPs greater than 90% in these patients. So the eligibility for the RAMP protocol includes any patient that's greater than 2 years old that with a diagnosis of asthma or recurrent wheezing. and where foreign body and vocal cord dysfunction has been ruled out. The exclusion criteria include patients with chronic lung disease, bronchiolitis, bacterial pneumonia, neurological disorders, immunodeficiency diseases, tracheostomy patients, and our cardiology patients. So to look at their history, you always want to look at the severity and the duration of the symptoms, including with exercise and if there's any sleep disturbances. You want to look at all their current medications, the way in which they're taking them, their dose, how frequently they're taking them, and their response to their deterioration with each dose. You want to know the time and onset of the present exacerbation. You want to know the risk factors related to asthma-related death and their level of asthma control at home. In addition, you would want to look and assess for their patient family history of asthma, of eczema, of smoking, of allergic rhinitis, of sinusitis, of nasal polyps, of eczema, and of BPD. In looking at their physical examination, you want to evaluate the patient's ability to complete a sentence. Are they dyspneic? Are they able to actually say words to you? You want to look at their pulse rate. You want to look at their respiratory rate. You want to look and see how they're using their accessory muscles. You want to look at the severity of the respiratory system symptoms using the CRS score, which we will go over in just a minute. You want to evaluate for rhinitis, increased nasal polyps, and mucosal swelling. So here you can see the CRS score. It's a little bit difficult to see. But here on the first score you have the respiratory rate. So it shows with each age group what their respiratory rate would be and what score you would give them. The second one is auscultation. The third one is the use of accessory muscles. The fourth one is mental status. Then their saturations on room air and their color. And so the way we would score this, you'd make a score for each quality on the side there, and then you would add up each of the scores to get your complete CRS score. So with a score less than 3, you would administer either albuterol or levoalbuterol with an MDI, and you would give 1 dose or 6 puffs. You could consider giving dexamethasone orally here with a patient with a less than 3 score. If you do your CRS scoring and you're finding that your patient is anywhere from a 4 to a 7, you would go ahead and administer dexamethasone. And at this point, you could probably give an IV dose if they're working a little bit harder and may not be able to go ahead and take the PO dose. You would administer your albuterol via the nebulizer. You would give up to 3 doses, every 20 minutes. And you would also go ahead and add your ipratropium bromide, which could be given up to 3 doses as well. At this point, you would consider giving magnesium sulfate. Now for a patient where you do your score and your patient's actually an 8, if they're in impending respiratory distress, you would hopefully look at, get your online medical director online and let them know, and then you would go ahead and prepare to intubate this patient. If, however, they have a CRS score of 8 and they're still looking okay, where they're not in impending respiratory distress, you would go ahead and follow the previous instructions. You would give your IV dexamethasone, you would go ahead and put them on a nebulizer with albuterol, you could add the ipratropium bromide, and then at this point you would go ahead and give the magnesium sulfate. So adjunct therapies that we don't use very often, we do use them every once in a while here with our transport team, is IV terbutaline. We could also do subcutaneous epinephrine. You could consider non-invasive positive pressure ventilation. And then you can also, and after all those, then you would continue to assess and go with the ramp protocol. At any point, if there is impending respiratory distress, you would stop, go ahead and intubate the patient, and then continue to assess. With the rank protocol, you continue to assess your patient after each intervention is done. And so for any patient that with your repeat assessment you have less than 3, you would go ahead and wean their SABA via the MDI to 4 puffs. In our emergency department, they have their criteria for discharge is if they remain with less than a 3 on room air and they're sustained at that for at least 1 to 3 hours after their last dose, then they're able to go home. For us, that doesn't really apply because normally our patients are pretty sick, and so we end up bringing them to either the PCU or to the ICU. Now, if we do an assessment again and our patient is between 4 and 7 on their CRS score, then you would consider continuous albuterol. You would also consider the ipratropium bromide if they haven't received their 3 doses, and then you would go ahead and administer the IV magnesium sulfate. With a poor response and with a continued CRS of 8, you would repeat the previous instructions. So if they haven't received a dose of dexamethasone, you would go ahead and do that. Surely they would have gotten one by now. And then you would go ahead and put them on continuous albuterol. You would give a dose of ipratropium bromide if they have not received their 3 doses. And then you would also go ahead and give the magnesium sulfate as well. At this point, you might think about giving IV terbutaline and possibly sub-Q epinephrine if they were continuing to deteriorate. And with these kind of patients with our continuous albuterol, we would normally bring them to our PCU or to our PICU for further management. So just to go over a few of the medications that we use on the RAMP protocol, the first line is always our albuterol or levoalbuterol. We normally just use albuterol. It's a short-acting beta-2 adrenergic bronchodilator that helps with bronchospasms. The ipratropium bromide is an anticholinergic medication that helps to open up the smooth muscles and open up the bronchi. Another medication that we give is our dexamethasone, and our dosing for that is 0.6 milligrams per kilo per dose, and you can give it either orally or IV, and it just helps with the treatment of asthma and it reduces swelling of the airways. Our magnesium sulfate is used as a bronchodilator in asthma exacerbations, and our normal dose of that is 40 milligrams per kilo per dose with a max dose of 2 grams. And we would give that dose 1 time. Our drug that we don't use too often is our terbutaline. It is a beta-2 adrenergic antagonist, that may be used in the treatment of acute asthma exacerbation as a bronchodilator. And that dosing is 0.5 mics per kilo per minute. You can increase by 0.5 mics per kilo up to 3 to 6 mics per kilo per minute. And last but not least, we have our epinephrine, which we would give subcutaneously. You normally give a dose of 0.1 milligrams per kilo per dose of the 1 to 1,000 solution. And again, we don't use that very often, but it is an option that we have if we need it. So overall, our goals of therapy are to reduce the frequency and severity of asthma exacerbations and to reduce the sequela by maintaining asthma control with the least amount of therapies and medications that we can for these patients. Intensive education and monitoring are required to keep these patients under good asthma control. So we have a case study so we can see how well you learned your CRS scoring. So there's a transport called to pick up a 4-year-old male that has a history of asthma, eczema, and allergies. His respiratory rate is 68. He has severe intercostal and substernal retractions, and his oxygen saturation is 86% on room air. He is irritable and looks tired. His skin color is pale, and his lips look dusky. What is his CRS? So if we look at it again, we're looking at his respiratory rate. We're looking at the auscultation. We're looking at the use of accessory muscles, the mental status, and the room air, his saturations on room air, and his color. Can anybody tell me what a CRS score is?
Based on the chart you handed out, I'm going to say a 9.
Okay, you're correct. And so in this case, what would you do first for this patient?
Administer oxygen. case study for you guys.
You arrive at the bedside of a 2-year-old male with history of pulmonary stenosis and TED. The patient has a respiratory rate of 45. He has mild depressed air movement and crackles and wheezes bilaterally. Moderate use of accessory muscles. He is irritable with oxygen saturation of 95% on room air and has pale skin. What is his CRS?
5.
Okay. And again, what would you do first for this patient?
Give them oxygen.
Okay. And then do you know, does he qualify for our rank protocol here at Texas Children's?
No.
Right. Because he is a cardiac patient, he doesn't fit the eligibility criteria for this. All right, any questions?
I have a question about continuous albuterol. What is the dosage on that one?
So normally when we go ahead and after we've done our 3 doses and they're still not improving, we would go ahead and put them on the continuous dose, which is 20 milligrams per hour. We would keep them on that until, we would keep reassessing. Okay, any other questions? Okay, well that concludes our talk on asthma.